What up, everybody? This is the Modern Medicine Podcast. I am your host, Dr. Dennis Tien, graduate of Tufts Medical School, the Harvard School of Public Health, and a practicing primary care physician, here to bring you all the latest in the world of medicine and help you navigate through all the misinformation, all the things that are out there, all the stuff you read on the internet, and to bring some truth around your life and your health. And with me, as always, is my producer, my friend, and my co-host, David Yaz of the Boston Podcast Network. How are you doing, man?
What's up with you, Doc? I'm good. We finally got some warm weather, and now I'm already complaining about it. It's too hot. It's too freaking hot.
Yeah, we've gone from one extreme to the other, haven't we?
Yeah. So I'm dealing with a little bit of a sunburn, but I'll live.
Well, we got a great episode. You know, the 4th of July is coming up. There's going to be driving. There's going to be traffic. So you can keep this podcast on and actually hear information that might benefit you, that might be interesting to you. We have a great episode today, a great roster of topics, and a terrific guest, Dr. Jonathan Croopnick, a hematologist and oncologist, who's going to answer, I think, some great questions about cancer, about your blood, about all the things that he does. I've been privileged to have a great professional relationship with him. So let's get right to it. I think we should start with the guest today, Dave.
Let's do it. I happen to know the good doctor myself, and I've known him since he was 14 years old. But that's a story for off the podcast. I'm not going to tell him any of those details from when you were a young man. But you were always a nice young man.
Wise decision.
Well, Dr. Croopnick, thank you so much for joining us. Dr. Croopnick, you have been a huge asset to my practice, my go-to hematologist, someone that I always am able to call on to help me out when I get into these complicated hematology patients. Now, I know you've had a lot of changes in your practice over the last couple months, so tell us about your practice, who you're affiliated with now, and the direction you're headed in.
So I was with Stewart initially about 8 years ago when I came from Sturdy Memorial Hospital, became the medical director. I was with Stewart until they dissolved a little less than a year ago. And Brown University, formerly Lifespan, out of Rhode Island, came in, and you're aware they bought 2 Stewart hospitals. They operate our building in Foxborough, which is where my practice is located. We were a Norwood Hospital affiliate. Norwood Hospital in June of the pandemic flooded. It was quite a time. Yeah. And so we've been without a hospital, but still a Norwood Hospital affiliate. We're now Brown University Health, and Morton Hospital is our main hospital. And we're hoping one day that Norwood will be back, which we feel strongly it will be. And if I had it my way, Brown, who does a great job, will take that over too.
You know, John, your practice is part of something we've talked about on a couple other episodes of the podcast, which is this sort of deterioration of that network of specialists in Norwood. And everyone kind of, since that flood in June of 2020, all these great doctors that were in the Norwood area kind of eventually having to pick up and go somewhere else because Norwood just wasn't progressing as fast as it needed to.
Right, exactly. You know, it's not the pandemic where people went other places. It was really the flood, because you need a central core hospital where everybody meets up.
Right.
Why you need that, especially in that community.
It's essential, and we talk a lot on this podcast about the loss of Norwood Hospital, and I feel it in Dedham too, where I have so many old sick patients that cannot and do not want to go into the city. And they really need that sort of linchpin in this area for their medical care, and it's gone. And like you said, you used to work at Sturdy. That's kind of far away. Newton Wellesley's kind of busy in of itself. Beth Israel Needham's a terrific place in Milton. They're overwhelmed. They've responded well, but they're overwhelmed. So we really miss Norwood Hospital.
Indeed. You know, there's a lot of communities in that area, not just Norwood, but Westwood, Walpole, many communities. And, the other hospitals are welcoming to our patient, but they're stretched kind of thin themselves. So they would be just as happy with Norwood Hospital back up and running.
100%. Let's talk a little. I got some great clinical things I want to run by you. I think that some stuff that people will find interesting. And I want to start with something that I am guilty of, like I think every other primary care provider is guilty of, but I think a lot about, and I'm trying to stop doing it. In fact, sometimes I'm not doing it. And that is the inclusion of a complete blood count in an annual physical. So if you go for your annual physical, a doctor, oftentimes, whoever you see, they will get a routine CBC. This is called the complete blood count. It measures your red cells, your white cells, and your platelets. Sounds great. People want the test. It's information. The problem is when it's been studied, a lot of the medical societies, the U.S. Preventive Service Task Force, for example, they recommend against it. Common practice, but not really evidence-based practice. I want to know what your thoughts are about getting, as a hematologist, about getting a CBC as part of an annual physical exam in just a routine healthy patient.
Well, as a hematologist, I certainly think that a CBC would be very important to get. Of all the blood tests that are done, it's relatively inexpensive, very informative. Like you said, you get the white cells, you get the red cells, and the platelets. I mean, those are the big three. And the white cells are made up of many other different kinds of white blood cells, which we also get. And to me, the importance is that there are many conditions that are asymptomatic that can be picked up with a routine CBC. For example, chronic forms of leukemia is the most common way that we pick up CLL, chronic lymphocytic leukemia. And it's not that it needs treatment right away. Many patients don't, but it would be good to know in case something were to happen for us just to keep an eye on. So I think annual, maybe biannual, whatever the PCP is comfortable with, it's very reasonable to do.
So why do you think some of the larger medical societies haven't really recommended affirmatively to do it? Like why is it's something I do on almost everyone, I'd say over 45 for the record, so I'm right there with you. But why is the U.S. Preventive Service Task Force, why have some of the larger medical societies maybe shied away from saying this is something that absolutely should be included, like a cholesterol test, for example?
Yeah, well, because probably most of the time it's not going to be very helpful. It's just going to be completely normal. And, perhaps the dollars are best spent otherwise in more important areas. But again, because it's a relatively cheap test, to me, it just makes sense. Whenever we order something, the question is, we've always been asked, what are you going to do with the information? And if we say most of the time, well, probably not much. They may recommend against it, but it's a recommendation, and we should take it as such.
I do think that some of those larger organizations like the U.S. Preventive Service Task Force, I do feel like they're a little too focused on cost effectiveness and a little not enough focused on like the actual patient and what's good for them.
That's true. Admittedly, most of the time we order a CBC, everything's going to look good, much like when we order electrolytes and kidney function and all that. But I'm not sure anybody's recommending, against that either. To me, it's basic because it gives a good insight of the bone marrow. People think of the bone as just a solid structure to move limbs and all that, which is absolutely true. But don't forget the inside of the hard part of the bone is the marrow. And one may argue that's the most active tissue in the body. And that's responsible for making all the blood cells. So it gives a relatively inexpensive insight into what's going on in the bone marrow to pick up those few individuals that may need further workup.
Is there an age that you would recommend that people start to ask their doctor for their this test? Is it 40, 50, 45? I mean, do you?
No, I see this checked in pediatrics all the time, right through, the latter decades of one's life. So, there are disorders that can affect that whole spectrum of ages. And if it can be picked up simply, then to me, that would make sense.
Excellent. I want to talk to you a little bit about vegetarian diets and how they affect blood function. This is a topic a lot of my patients ask about. It's a topic that affected me a little bit recently. And that is when people don't eat a lot of meat, how does that affect their blood? As a PCP, I'm thinking the whole picture, and I'm looking at how high saturated fat diets can affect cholesterol and affect cardiovascular health. But there's another side to this, which is, the importance of maybe eating heme and eating iron for our blood. So could you tell us a little about, how you as a hematologist look on vegetarian diets and how they affect blood function?
Yeah, so the main nutrient that we're focused on would be vitamin B12 if one is a vegetarian or vegan, because that's in animal products. A lot of patients say, "What about my iron?" I can't get that's everywhere. That's in leafy green vegetables, meat, so you can't really avoid iron. So I'm not worried about iron. Everything's rich in iron. It's just a vitamin B12, but there's supplementation, which is easy to do. You can do injections. You can do pills. It's cheap. It's safe. And in those very few patients that have severe B12 deficiency, they could be pretty sick. So it's really something that, that we shouldn't allow to happen. Same with folic acid. It's one of the building blocks of the red blood cells. In the American diet, where it's supplemented with folinic acid. Usually when we check those levels, they're off the charts, which is safe. I'd rather they be high than low, but the B12 the focus.
Do you think that vegetarians should make it a point to talk to their doctor about testing for B12 and folate? Again, this is something that wouldn't be included on a CBC in a lot of labs.
Correct. Yeah, it's not part of the CBC, and they should have the B12 folate and iron checked routinely. Often it's the case that we don't find deficiencies, but it's a simple question to answer, though.
Yeah, I think it's something that it's just the larger point. I think if you're a patient and it's important that your doctor knows how you eat. Like, I don't think a lot of doctors I think don't discuss nutrition enough with their patients, but I think it's really important, especially if you're eating a specific kind of diet. I think it's really important that patients and doctors know that, and that patients convey that to their physician.
Yeah, I agree. A nice healthy diet is really what's recommended, and you get everything you need.
Okay, absolutely. Sorry, go ahead.
Oh, that's it. Thank you.
Okay, I want to shift gears a little because you're also an oncologist, and I want to talk a little bit about a few of the hot topics, I think, on oncology. And this is what I want to start with. I perceive in my office that people with advanced stage cancer seem to be doing better now than they've ever done before. That's not to say that cancer isn't a serious diagnosis. It still is. It's not to say we have cancer cured. We obviously don't. But I feel like there are way more options for most cancers, and patients seem to be doing better with most cancers now than they've ever done before.
Since I graduated medical school in 2001, the field has completely changed. Early on, we have chemotherapy, what we think of as traditional with the hair loss and the low blood counts, and we still use that all the time. But as we do more research and we figure out what are the mechanisms in the cell, in the blood that affect cancer, we find better and better targets. In the research that's done in Boston, for example, can find ways to target whatever pathway may cause cancer. Now, that could be something, if we think of the greatest success, CML, chronic myelogenous leukemia with the Philadelphia chromosome, if you remember that one, that's unique in that it's basically one pathway that drives the cancer. So if we can block that, we can pretty much cure the cancer. And that's a huge success because before the development of a blocker, if somebody had that diagnosis, it would be intensive chemotherapy and all the complications. Now, because they found a simple pill called Gleevec initially, there's other pills, now we say, here, take this pill, and we can pretty much drive almost everybody into remission. So it's really understanding the pathways. I wish everything had one pathway like that, but most have multiple, and you build up resistance.
Yeah, and it's funny because my father is going through this right now. I don't know if I've told you this, but my father is stage 4 non-small cell lung cancer. He was diagnosed in October of 23, and he is one of the small subset of patients, and you'll know more about this than I do, that has the GFR mutation?
EGFR, yeah.
EGFR mutation. Yeah. So he has been able to take Tagrisso, which is a targeted therapy. And I think Tagrisso is why he's alive today. And I think Tagrisso is why he's done so well. He doesn't have to this point, have done like the traditional chemotherapy. But I think you see more and more of these like targeted therapies for more and more types of cancer than ever before.
Exactly what it is, personalized medicine, as we call it. Now that we understand the pathways better and we can target them and make effective targets that are well tolerated and effective and safe, we're seeing better results over time. And like I said, it's change in my, in my career, and I haven't been around forever, but it'd be tough to imagine practicing a generation ago where we didn't have any of this.
Right.
Especially with the therapeutic agents, but also the imaging, PET scans and CAT scans and MRIs. One day, all they had were X-rays.
Right.
Imagine practicing then.
Unbelievable. And in my father's case too, you speak about mutations. So he has gotten a little bit resistance. They were able to send his cancer cells to a laboratory and analyze them for how tolerant they've become to the Tagresso, right? And they were also able to analyze other drugs. And some of the drugs that now they say that they can go to when the Tagresso stops working weren't even FDA approved a year and a half ago or 2 years ago when he got diagnosed. That's how fast this whole stuff is changing.
Yeah, there's a lot to keep up on. When I first graduated, that's when those EGFR blockers just started, and they're for certain mutations. Now, the guidelines are, I think there's upwards of 10 or 12 different mutations where that are targetable, where we have a pill for it.
Yeah.
So, it's almost like an alphabet soup, not just with lung cancer, but with other cancers too. But lung cancer is a great example of that. We always, these mutations are not very common. So often we can't use them, but anytime we test the tissue, we always root for these mutations because it's safe and more effective and easy to do at home than coming in for infusions.
I think they said 10 to 20% of people have the mutation he had.
Yeah.
So that was the only fortunate break he had. And it's crazy because there are still, frankly, some cancers that are really bad to get too. We definitely, I feel like every couple years we're taking a cancer and we're putting it from the really bad pile into, okay, well, we can kind of treat this pile. Blood cancers in particular have come a long way. There are still some cancers that are really, tough to get too, like pancreatic and certainly some of the gut cancers for various reasons. We still seem to struggle treating them in a lot of ways. But I think with time, hopefully more and more of these diseases, more of them will move from the bad pile of, okay, old school chemotherapy and limited options to the new school pile of, targeted agents, gene therapies, and specific therapies.
We're already there in personalized medicine. What's interesting is just because we may know the pathogenesis of certain cancer cells, and just because we can make blockers in the pathway doesn't mean that they work. And that's the importance of the clinical trials. We have a great idea and we make a drug. Well, let's put it in prime time, phase 2, phase 3 trials, and really see if it works. And that's when we kind of figure it out.
So what is the future of cancer treatment, and what do you think things will be like in, say, 5 or 10 years?
I think we're headed with more and more personalized medicine. All of the molecular techniques are improving. We can make better and better and safer antibodies to block certain parts of pathways. And when we enroll patients in clinical trials, we're sort of chipping away therapeutically over time. So when someone comes in today for whatever cancer, the reason why we have a standard of care is because there are patients who participated in clinical trials years before that.
Right.
The reason why we got there. So 5 years, it's a very exciting field and it changes quickly. And we have a lot of good success stories.
Do you think that AI will quicken the pace with the kind of AI revolution that's come in the last year? David knows my position on the robots is I welcome them. I do not fear them. I think they will help us. I mean, I'm looking at a world right now where Trump and the Shah of Iran are lobbing missiles at each other, and I'm like, bring on the robots. Like, I'm ready for them to have a chance. But
yeah, we're on the record. We just want to know when the robot overlords take over that we're come in peace. We're your friends, robots.
Exactly.
So, yeah.
But don't you think that AI is going to really quicken the pace of all this?
I think it could possibly help. Depends upon their algorithms. Depends upon their judgment. I mean, you have to realize these are, when we're sitting face to face with patients and families, they're real people. Where's AI going to be with that? Well, hang on, we'll find out.
It should be really interesting to see. I'm hoping it will quicken accelerate the pace of growth and maybe, lead to something. And we've been hearing about some of this stuff for decades, and it's just like like you said, because of the way that science is done and clinical trials, like it's slow. It's slower than we want it to be, but it does feel like we're hitting a critical mass, and I just feel like once we hit that spot, and I'm hoping the pace of some of these things we've been dreaming about since this turn of the century, since you got into practice, some of those things actually come into reality and just the pace accelerates.
Oh, completely. I mean, if we take some examples, multiple myeloma, there are so many effective drugs. The question is, how do you sequence them?
Right.
And if you go to, hear the top researchers talk about it, you may get different opinions. There's no one size fits all. Right. And, to me, that's almost like a good problem to have, a bunch of effective agents. Which one do we use? Well, more research will help clarify that.
And to the point, I mean, multiple myeloma was a very bad diagnosis 25 years ago, and now it's way more treatable.
Well, yeah, but back then, before I was practicing, and somebody had that diagnosis, median survival would be in the order of months, and we've increased that, to 7 to 10 years on average.
Right, and going up, it's unbelievable.
It shows.
Yeah, go ahead. All right, and then a couple more quick questions for you. I want to ask about what is your opinion? We're talking about cancer, and early diagnosis is obviously key. I think something I know a lot about because of my background is cancer screening and the importance of early diagnosis. But do you have an opinion about the blood tests that are proliferating now? Like, you see a lot of individuals that, like, a lot of products out there that say they can diagnose cancer by taking a sample of your blood. None of these are really FDA approved or really vetted. Do you have any thoughts about that?
Well, we're talking about tumor markers.
Tumor markers.
Tumor markers. There's tumor markers for many cancers. That blood test that we use, the problem is they're not perfect tests. Right. So they're helpful if they're elevated initially, because that's one way we follow patients. If the marker goes down with treatment, then we're probably killing a lot of cancer cells. Imaging usually would support that. But the problem is, a cancer may not elaborate these markers, and so it wouldn't be helpful. Ideally, it would be good to use them in screening. The benefit of screening is that you catch it early and you live longer. And breast cancer, with mammograms, that's the case. Colonoscopy, but other cancers, like ovarian, pancreatic, clinical trials are ongoing to figure out what's the best screening method. And tumor markers are playing a big role, and really, more screening is better.
But certainly these blood tests are different than, traditional. The screening I might do is a PCP, like colonoscopies and mammogram. That's sort of my wheelhouse and domain. I mean, these sort of direct to consumer products that offer, we can diagnose you with any number of tumor markers or cancers. I just think it's really, really interesting. And it might even be a little dangerous, frankly, because I don't know how reliable some of these products actually are.
Well, with alternative medicine, I don't think that they necessarily need published data, to support is somewhat unregulated. So I would advise caution, speak to your physician. We use tumor markers mostly after the diagnosis.
Yes.
And in many cases, prostate cancer, testicular cancer, for example, it's very helpful, and they can be quite accurate. In other cases, that may not be the case.
So I had a drug rep, I don't even remember the name of the product, a couple months ago, come to my office and pitch a product for people that haven't been diagnosed with cancer yet. Just, hey, let's do 100 tumor marker, 100 panel test, and we can diagnose you with cancer on a blood test. And I think that's the stuff people need to worry about, be skeptical of.
Absolutely. Or maybe they're testing certain genes to see if they harbor those genes.
Yeah.
But we generally don't use tumor markers alone as screening tests.
Excellent. And then one last quick question, just your opinion as an oncologist. We're seeing so many more cancer cases in younger people, and I think there's a couple things that go into that. One of them is increased screening from doctors like me. We're doing a better job of picking up these people. But what are the reasons that you can identify as a hem-onc doctor about why we see so many cases of cancer now in people under 40, under 45, in their 30s. What do you think some of the reasons are?
Well, I mean, I'm hoping that we're doing more screening. A lot of the times we just don't know why rates are going up or rates are going down. There are more and more participants in clinical trials. And I feel like nowadays in this country, we overuse a lot of the resources. So the more we look for, the more we're going to find anyway.
Right.
The trials over time will better answer that question.
Well, let me give an example that just to illustrate what you just said, because you know more about this than I do. But correct me if I'm wrong, ductal carcinoma in situ, which is I guess you could colloquially call it a borderline cancerous condition of the breast. Many of those cases will spontaneously resolve if they're never diagnosed or treated. Is that not accurate? A percentage of them?
I'm not aware of data specifically that would support that.
Okay.
Ductal carcinoma in situ, it basically have cancer cells that haven't broken through the membrane. We also call it stage 0.
Yeah.
And those are often picked up on mammogram. 3D mammogram does a great job in picking those up when they're just calcified, abnormal appearing calcifications that you can't feel the lump. So that's the importance of screening right there. One good example.
Absolutely. And maybe diagnosing and finding them. Okay, Dave, do you have any questions for the good doctor before we let him enjoy this beautiful evening?
No, I learned a lot as usual. Thank you, Dr. Croopnick. Outstanding stuff.
Dr. Croopnick, just tell us quickly, what kind of patients are you looking for people that are looking for a hematologist? How can they contact you, and what do you like to see in your office?
So we run a general hemonc practice, which means we see, quote unquote, everything. So we see hematology, benign or malignant. Benign could be anywhere from anemia to clotting problems, to red blood cell problems, to white cells, even platelets. We see that quite a bit. We see malignant hematology, leukemias, lymphomas, and we treat them right in the office in Foxborough because we do chemotherapy there. So, a lot of patients would rather be sitting in Foxborough than driving into Boston for the exact same chemotherapy. Right. We also, similarly, for oncology, solid tumors, we see, almost anything that comes our way. And if something is too much, or if one would prefer a clinical trial, then we're glad that we have all the hospitals in Boston and Providence to rely upon as well.
Wonderful. So if patients are out there and they have concerns about their blood, if they have concerns about potentially being diagnosed with cancer, and they're not keen on going into Boston and they want to get world-class, excellent medical care right in Foxborough, they can look you up, Dr. Jonathan Croopnick.
We have it there, and we've got a lot of connections in town, so we're not shy about referring if we need.
Jonathan, thank you so much for joining us, and you will certainly be hearing from me soon next time I have to send you a patient.
Thank you for inviting me. I appreciate it.
Thank you, sir. Have a great day. Okay, awesome. Well, that was great. Thank you very much to Dr. Jonathan Croopnick for joining us. Truly one of the best. And David, you had a personal experience with Dr. Croopnick recently.
Yeah, this wasn't by design. This is kind of a coincidence, because you didn't realize that I was acquainted with Dr. Croopnick. Yeah, but sadly last month my dad passed away. He was 84, and you were very kind in offering your condolences, Dennis, so I appreciate it. He had a long, happy life and all that. He had cancer. He had colon cancer, and it was late in the process. It's not ultimately what he died of. He died of kidney failure, but we walked into and met Dr. Croopnick when we were first considering chemotherapy, and he did actually prescribe it was at home chemotherapy. That's not what you call it, but it was like it was the pills. It wasn't it wasn't radiation. So for a while that seemed to be working, but frankly, my dad was at the end of the line. Once the kidney failure happened, there wasn't much to do. But Dr. Croopnick had a wonderful, you call it bedside manner. He's very, you can tell he's very calm. He's very measured, super nice, which was just important to my mom and dad. At the end of the day, what was important? It was for my mom to feel comfort through the process.
Yeah, well, it's great to hear that personal experience, to come from a patient, because I've sent him a lot of patients, and he's just a great guy. And like you said, he's very even keeled, which I think you have to be. He has actually a great sense of humor too, which I think honestly is how we survive in this business.
You have to, yeah.
You have to.
Yeah.
Sometimes a little bit of a sick sense of humor, but that's something you see in a lot of doctors and nurses, because what else can you do sometimes but laugh?
Yeah. I mean, you absolutely have to. You go the whole thing. You be crying one minute and laughing the next. That's kind of what life's all about.
Especially what he does, because let's be clear about one thing. Like in my office, I get a lot of patients, and we're probably seeing almost 300 people a month in my office. We might diagnose someone with cancer or serious disease like a handful, like 3 to 6 times a year, where something really bad walks through the door.
Right.
He does it all day, every day.
I know, that's right.
He does it all, the oncologists, all these nurses, these doctors, all day, every day, dealing with the worst of the worst.
Yeah. And, before we started recording, he was very kind. You said he heard about my dad, and please send my best to my mom. And, yeah, I can't help but think that happens to him all the time. He meets people. Yep. He didn't get to know my parents very well, but he got to know them a little bit. And my dad's gone. And it's sad for us. For him, he must have to deal with it. So he's got to have that temperament, and I think he does.
I mean, my wife is a cancer nurse too, and she has that temperament too. But you just have to be, I think, very even-keeled and very compassionate, compassionate. But at some point, like, yes, you can't help but take your losses into your heart as a doctor or a nurse of any kind, because you're a human being and they're human beings. And I do think when doctors and nurses reach the point where they're at what we call compassion fatigue, and you do see that. I mean, that's when it's time to I think, hang it up and do something else. But great doctors like Jonathan, they're able to give that compassion to every patient.
For sure.
Excellent. All right, let's move on to In the News. We got some interesting stories.
You like the new sound effect, Tim?
I love it. This is great. This is great. I'm rocking out over here. Okay. Well, we're going to start with the gift that keeps on giving for anyone trying to do a podcast about medicine, and that is the man, the myth, the legend, RFK Jr., who continues to make news, some of it good, some of it not so good, in the news. I pulled this article from BBC, but it was everywhere. I could have pulled it from anywhere. U.S. Health Secretary Robert F. Kennedy, a vaccine skeptic, has removed all 17 members of a committee that issues official government recommendations on immunizations. He did write an editorial in the Wall Street Journal explaining his position. I got to be honest with you, Dave. Last episode I said I didn't hate the Maha report. There were things in it I really liked, but I'm also going to call it like I see it. This does make me pretty nervous, because I don't know. I wonder what kind of biases RFK Jr. has. And it seems like it's pretty clear that he's kind of an anti-vaxxer, even though he's trying to say he isn't, or he's a and when you just purge the whole committee, it makes me afraid of what direction they're going to go in the future.
Yeah, by all accounts, the people he has added to this panel don't have the experience that the people he dismissed did. And, this is all about science. It's all about science. It's please no theories or anything else. We've talked about it on the pod before, but I've been frustrated by hearing that vaccines cause autism, and there are still whispers of that out there. My son has autism, and so I'm kind of offended by it, because it's not backed up by science anywhere.
Right.
And this is kind of an extension of that.
Right. Well, he said, I mean, if you really want to make effective health policy, isn't it important to have dissenting voices? And maybe RFK could stand to learn something. RFK Jr. could stand to learn something from those 17 experienced voices that he just silenced. Instead, he's going to replace them. And who is he going to replace them with? And what is the future of vaccination in this country going to look like if you have a panel, an advisory panel, that is like decidedly anti-vax, or at least leans that way, and what things are going to change? And we're at a critical time where we're starting to see the return of some of these. In fact, are we going to have a return of polio and measles and mumps and rubella and things I didn't have to deal with, you didn't have to deal with? Right. Is that what it's going to take for the pendulum to swing back? But I think it's traipsing a little bit into scary to me.
Yeah, and it smacks of like conspiracy theory stuff, and that's what worries me is why is this a priority now? It's almost like we had the vaccines that we had were working. How do we know? Nobody has polio anymore.
Right,
you
right.
know what I mean?
100%.
Yeah. And so, like, for him to sort of attack this smacks of some. Now, you've talked about it before. That there are people that become injured from vaccines, and you want to deal with them, fine. But that seems a very small corner of the medical world for the health secretary to be announcing these big sweeping changes.
100%. And in his editorial, he said, that there was a crisis of public trusts, and and that's maybe a little bit true, but I don't know, like, does replacing this whole panel, does that feed into the crisis of public trust or solve it? Like, to me, this almost makes it worse. Like, see, everything was broken. We have to tear it down or replace it because everything was broken. I don't think everything was as broken as RFK Jr. does. And do I think there's a modicum of truth in what he says? Like, maybe we need to be a little more scrutinizing about things. Maybe there's a kernel of truth in there that we could all, there's a middle ground, right?
Right.
But to sit there and say that we need to rip this down or replace it, well, guess what? The system's kind of working, right? Polio isn't around. I didn't have to deal with it. Did you?
No.
Rubella
Polio,
is measles.
rubella, yeah.
All this stuff. Smallpox is eradicated. So, obviously we did something right in the last century too. So let's not go back to the Middle Ages here, the medieval times, and repeat history.
I'm with you.
Yeah. Okay. Let's move on. Next topic. Okay. This is a good one. A new study that was in the journal. I'm trying to find the name of this journal. It was one of the cardiovascular and diabetes journals. Okay, and I can't see it because my papers got blurred. But it basically found that staying active for just over 2 hours a week can significantly reverse the rates of prediabetes. So the reason why I think this story is interesting is because, do you know, like, a third of this country is pre-diabetic right now?
Wow, that's we may lead the planet in that, I'm afraid. Right?
We probably are right up there if we don't lead. And to think, and what this study found is that staying active for just 2 hours a week, so that's like 30-ish minutes a day of just like moderate intensity. We're not talking about running the Boston Marathon here. We're talking about a brisk walk. Can help reverse prediabetes in a lot of people. And the angle on this that I think is also interesting, Dave, is, and we talked about this the last 2 episodes, that's it right there. You just pulled up the link. Cardiovascular Diabetology and Endocrinology Reports is the name of the journal.
Right.
Everybody that's on Ozempic and doesn't have diabetes, a lot of these people, the majority of them, they're gonna lose their Ozempic. So it's gonna be back to lifestyle measures for a lot of these people, unless they're gonna pay out of pocket, which isn't realistic for most people because it's expensive. So it's gonna be back to old-fashioned exercise.
A lot of those people are not going to be happy. I have a feeling.
Right.
I mean, I know people on Ozempic, and it's. I guess they know what they were signing up for. It's not guaranteed to keep the weight off forever, but all this means is fall back into healthy habits, right?
That's it. And let me tell you, just so we're clear, everyone, I think if you're pre-diabetic, you should know this, that you have cardiovascular risk just from being pre-diabetic. There have been papers, we say diabetes is when your hemoglobin A1C is 6.5. We say pre-diabetes is when it's 5.7. That test basically means the percentage of your red blood cells that have a sugar stuck on them. We can extrapolate out your average sugar over the last 90 days. So if you have 5.7%, you're pre-diabetic. If you have 6.5%, you're diabetic. But studies are clearly showing to us that diabetes is not binary. It's a continuum of insulin resistance, and that once you walk down that pathway of insulin resistance, your doctor may say, pre-diabetic, you have higher rate of strokes and heart attacks if you're pre-diabetic.
So get out there, people.
Get exercising. Get moving. Okay, next one. HIV protection with just 2 shots a year. FDA approves new Gilead drug. This is I think a big deal. I think sometimes we forget that HIV is still very much out there.
Sure.
It's a big problem for a lot of people. You talk about a success story in biomedicine over the last 30 years. I mean, what we thought and what HIV was in the 90s, in the 80s, and what it is now based on biomedicine and effective treatments is a game changer. But this is the latest sort of advent. This is not a vaccine. This is an antiviral drug. But instead of having to, take a pill every day or twice a day and maybe deal with all that and some of the side effects, this is an injection that you get twice a year, every 6 months.
Amazing.
It's amazing.
I wonder how they come up. The name of the drug is lenacapavir?
Yep. Lenacapavir, otherwise known as Yeztugo.
I want to know where they got that name, Yeztugo.
Yeah.
It sounds suspiciously like my name.
It does. They may have named it after. You should ask for royalties.
Well, for a while there was it a birth control called Yaz, Y-A-Z?
Yep.
Yeah.
Did you get anything from that?
No, nothing.
Nothing. That's a scam. You are a lawyer,
I know.
You could sue them.
Should have gone into action, yeah.
Absolutely. Well, this could be a real game changer. So for people out there that are doing PrEP and high risk sexual behavior, this could be something that really changes. And this is approved for both men who have sex with men and heterosexual sex as well. So some of the other PrEP therapies are only approved for homosexual sex. So this is approved for both. So I think that is an important thing too. And there are parts of the world where access to treatment isn't very good for you can't get your daily Truvada. You can't in Africa and in South America and parts of the world. So public health wise, this could really globally make a huge difference.
It's good to hear about this because I was just reminded, someone brought the subject of Magic Johnson, and I'm an older man than you, Dennis, but I remember being in college and hearing about when Magic Johnson contracted HIV.
Yep.
And it was so shocking, and everyone assumed he was not long for this earth, and of course he's still around and everything. And because the AIDS has been controlled, I don't know if that's fair to say, that we almost never talk about it.
That's right. And I was in middle school when Magic Johnson got diagnosed. It was like I don't want to trivialized. It was like Kennedy got shot.
It was
a huge deal.
It was shocking, yeah.
It was shocking. It was on the cover of Sports Illustrated.
Yeah. Mm-hmm.
So, he's done well. A lot of people have done well. Mm-hmm. It's really been a different game now than it used to be. Yep. Okay, last in the news topic, and this is a big one, and I have not talked about this yet on the podcast. If anyone watches my local access cable show, and I mean that literally, if anyone watches that, because I don't know if anyone does, but if anyone actually watches the Dr. Dennis show on Dedham TV, we talk about this every episode for the last 2 years, which is the marijuana study of the month, because there is so much literature coming out right now about the health consequences of cannabis use, and it continues to, I think, surprise me how adverse some of the effects are in studies. And let me just say, I knew, if anyone that was paying attention knew that cannabis and THC was really bad for your brain, even in relatively small doses. That was clear from the literature before this whole legalization push happened. But now that we've had this push and we've been able to have more studies and research, I am shocked by the cardiovascular effects of THC and cannabis. I knew there was some stuff there. I didn't think it was this strong and this profound. And some of the studies that we're seeing right now are really earth-shattering, I think. The one I'm referring to just published a few weeks ago in JAMA Cardiology, Association of Endothelial Dysfunction with Chronic Marijuana Smoking and Edible Use. And that's important because it's not just smoking, it's eating too. And how it has similar effects on the inner layer of cells of your artery as tobacco use would, or anything else that could cause damage to your arteries. It is a atherosclerotic agent, and that's what's crazy.
Comparable to tobacco smokers, apparently. I'm just reading this from. I'm not a genius, but yet it applies to edibles as well. That's.
I mean, this particular study only looked at endothelial dysfunction. It used ultrasounds and some lab measures, to say what's happening to these cells in people that smoke and eat marijuana versus just people that don't use at all. So this doesn't mean, let's be clear, the study doesn't answer this, that this leads to strokes and heart attacks. It just causes a similar pattern of damage to these cells as we see in smokers who we know have lots of strokes and heart attacks.
Yeah, well, this is interesting to me because a lot of people turn to cannabis, THC, because of anxiety, because of stress, because of things that you would think would be bad for your heart. And so to hear that, so, I mean, does this change your stance on people who use cannabis regularly, but maybe not frequently? Because a lot of people see them as an alternative to what, opiates or antidepressants or whatever.
Well, here's the thing. Like, this is not in isolation, this study. There's been a steady stream of literature showing the cardiovascular effects. And in fact, there was a paper in March that was even more shocking, association of cannabis use with cardiovascular outcomes among U.S. adults, a very well done epidemiologic study. And what they basically showed is that people that had cannabis use disorder, which is a little bit murky how you define that, but it's basically someone that's using a couple times a week, I'd say.
Okay.
They had 6 times the rate of heart attack.
Wow.
These are people, by the way, under 50 with no cardiovascular risk factors. So no diabetes, no hypertension, nothing like it. Young, healthy people. 6 times the rate of heart attack, 4 times the rate of stroke. Okay. I think heart failure, don't hold me, this was something like 3 times higher. And they had 1.8 times the rate of all-cause mortality. So people that are using cannabis products 2, 3, 4 times a week heavily die twice as often as people that don't for some reason. So, I mean, the thought that this stuff, it doesn't have adverse health effects is just, it's fantasy. It's not the reality, and we have to start.
No free lunch.
And the scientists have to start saying it because it's not cool, it's not popular, right? It's going against the societal and cultural trend, the societal and cultural mythology that has been built up from like decades of product placement in movies and television, and the stereotypes we have, the harmless plant and the good-natured stoner, and all like these are not what the science is telling us, and we have to stand up and say it. Because if we're going to have legal THC, which we're going to have, that hinges on a effective public health message that tells people the truth, that if they choose to use this, these are the consequences.
It took a long time to get it right with cigarettes, and by get it right, I mean get the proper warnings out there, and get the tobacco industry to admit that it was harmful, which now seems fantastically obvious. But we have to remember, like with like anything else, we're usually wrong about things in the past as human beings. You know, we used to think the world was flat. We used to think that people in Salem were witches and things like that. And we march forward, but there are still so many things we don't know.
Right.
I'm reading from the notes from the study, and they don't know how THC damages blood vessels, but they know that it does.
Right.
And so there's going to be more to be learned.
Right. And again, I think the previous study, the one that showed the cardiovascular outcomes with cannabis use, it didn't distinguish between edible and smoking. And so it left it unclear. So you don't know. So this study the second study points to the fact that edibles seem to be doing some of the same things as smoking. I mean, I think it's easy for people to imagine, including myself, that smoking anything is going to be bad for your heart and your arteries. Right. But now we see there might be something intrinsically about THC. And just to give people some context, like I said, 6 times the rate of heart attack almost. The relative risk from tobacco use is 2.5, 3. So it was actually a lot worse to be a heavy cannabis user than to be a tobacco smoker. So I think we got to be real about the health risks.
Right.
All right. Any other thoughts? Wrap it up.
Yeah, well, we can do the your favorite feature, Dennis.
Yeah,
I've got it fired up.
The non-medicine topic of the week, the best. I got a couple quick things we're gonna go through.
Here's the intro. It's new. I hope you like it.
The doc is off the clock, so it's time for the non-medical topic of the week.
Nice.
What do you think?
I love it. Kick off your shoes, put up your feet, relax. We're done with the medicine part. Right. We're talking non-medicine topic of the week. I got a couple quick things I want to bring up to you in the news. Number one is, I didn't discuss this with you at all, but I'm going to throw this at you.
All right.
This is crazy. This kid that fell off the Disney cruise this week. Did you see this?
I didn't see it.
A kid fell off a cruise ship yesterday.
Okay.
In the middle of the ocean. 4-year-old kid jumped off the 4th deck and fell, and the father jumped in after her.
Oh, my goodness.
And then they had like a rapid response. You see this on a Disney cruise, and they saved them both within seconds.
That's amazing. We're looking at the video now. Maybe we're not. Hold
Yeah.
on. We're looking
We're
at
looking
an
at a
ad.
commercial
Sorry, we're looking at an
now.
ad
Sorry.
but when I get this, so we have video of this Disney cruise. Did she jump over a railing or something, or?
So I've been on 2 Disney cruises, and
Okay.
and I can tell you, I can confirm for you in the audience at home, it is pretty much impossible to fall off.
Yeah,
one of those
you would
boats.
think, right?
So I knew there had to be something missing. So I did a little internet research, and it turns out that the father put his daughter on the rail, according to
Oh.
eyewitness reports, to take a picture of her,
Right.
and she fell off.
Okay. Yeah, I'm looking at video of the rescue. I guess they don't have video of the fall, do they?
I don't think so.
Oh, okay.
No,
All right,
maybe
all right.
they do if they have everything on camera. It hasn't come out yet.
Yeah. Well, there was that tragic case maybe 10 years back or something of, I want to say, a grandfather who was holding his kid over the railing and
Yeah.
tragically dropped the child. Yeah, Disney doesn't need bad publicity, but it seems like they, we all think, as parents, we think about these things, right?
Yeah.
We always
Yep.
we always think of sometimes what's the worst thing that could happen. You're on a boat, your kid falls over,
Right.
So, but I don't know. Maybe Disney will spin it as a positive because it's a magical place and people.
Well, they made like a amazingly rapid response. I guess they have
Yep.
alarms around the whole boat if someone falls off. They knew that this kid fell off the boat before anyone could even say we need help. I mean, they had triggers in place to know what happened, and they had someone in the water within like seconds.
Yeah, Disney gets a bad rap for being like an evil corporation or whatever, and maybe they are. But I'm a big Disney fan. I didn't realize you like taking your family to the park.
I've done too.
Yeah. I took my kids last year for my birthday. We went to Disney for a couple of days because my son Adrian, the one with autism, it's his favorite place.
Yeah.
So it really is it can be really kind of magical. Yes, everything's fake and all that, and yes, when you're at Epcot Center, you're not looking at the real Eiffel Tower. Duh, we get that. But it's to me, it's the thing that puts them a notch above is maybe indicative of this. Who knows? But that the staff is usually tremendous. The staff is usually incredibly helpful. And
We've been to Disney 4 or 5 times, and we've done 2 Disney cruises. So
Yep.
I like Disney. I mean, it's all about family. It's
Yeah.
all about family. It's really
kids will
great.
remember that.
And honestly, reality's overrated. I want fake. Give me fake.
Thank you.
Give me fake. I like fake. Fake is nice. It's fun. It's easy.
Yeah.
I got reality for 51 weeks a year.
Yep.
Give me the fake Eiffel Tower and
Sure.
and everything. And that's what I want for 1 week a year. I want to go to Fantasy World.
I got a friend who just got back from Africa, and the whole family went and everything, and they went on a safari, as you do. I've never been, of course, but I said, so what was it like? He said, well, you get on the safari, and you're waiting to see the animals, and he goes, you know what it's like, Dave? You ever do the safari ride at Animal Kingdom Disney? And I said, yeah, of course. He says, it's really like that, except you got to wait longer for to see the animals because Disney does it right. Those are real animals.
They do a good job
Yeah.
of faking it and making it feel real. No question
Exactly.
about it.
Yeah.
Okay, next topic, very quick. I got to ask you, because you're a lawyer.
I am.
I don't want to get too thick into it.
Yeah.
But thoughts on the Karen Reid trial? It's over. What do you think?
I didn't watch like gavel to gavel like many people did. I wasn't as obsessed, but I used to work for Massachusetts Lawyers Weekly, and I got to know David Iannetti a little bit. Really respect him. And the defense did their job, and I guess you could say justice was done. Now there's that. I mean, it is hard to prove a murder case, a homicide case, beyond a reasonable doubt. It just is, and. The defense did their job, and if you want to be cynical about it and say, well, anyone who's got a lot of money to spend can get off on something like this. Well, something like this, where there aren't any eyewitnesses, other than I guess Karen Reid herself, then yeah, you can poke holes, and there certainly were a lot of holes poked in the police work and all that. So I think justice was done. Now, but if you want to play the game like what really happened, you're not going to get me to believe that there was some conspiracy with the people in the building. No, I think, again, I'm not going off of any knowledge or anything, but I think logic dictates that she hit him probably by mistake, maybe not. We know she was super drunk, and it was a tragedy. And I do feel bad for the family of the kid.
I 100% agree.
You agree?
Agree 100% with what you said. I mean, I personally, I think she did it, but I don't think you're ever going to get 12 people to look at the evidence based on the quality of the evidence and agree that she did it.
Yeah.
And I think that one of the things I'll say, and I have thought about why I think she did it, and most people have doubt or they don't, because I really don't have doubt that she did it personally, but like, I think that being someone that has a background in looking through science information and kind of rifting through it, like I feel like I had a skill set where, not to sound arrogant, but I think it's the truth, where like I could look at conflicting information and say that's BS and that's legitimate.
Right.
And I think that most people, certainly jurors, you know, if you're just a lay person and you know you might know 1,000 different things, but can you distinguish conflicting scientific information? That's a hard skill set to have.
It is, yeah.
And when most people are in that position, they're going to say reasonable doubt.
Exactly.
And that's why, and that's how people get off. And if you have enough money and you have enough resources and you're willing to do it, you know, and it's hard to prove. It's supposed to be hard to prove. This is our justice system.
That's right. It's the price of our system, is that sometimes we will get it wrong, but our system is set up so when we get it wrong, we want to get it wrong this way and not the other way, and putting someone in jail, you know, innocent people in jail. Right. So, but, you know, my son, I told you my son Griffin is applying to medical schools, and not that has any bearing on this, but maybe he thinks the way you do a little bit. He said, Dad, if the theory is true that a lot of people are banding about on the internet, all the armchair sleuths, you know, all the true crime fanaticos, that the people in the house conspired with the first responders, with maybe the forensic expert or whatever, like how many people, he goes, Dad, if there were like more than, you know, half a dozen people involved in this conspiracy, that just doesn't make sense. Yeah. Like, what, do they have little meetings where they say, this is what we're going to do? Yeah, that doesn't make sense.
Well, that's it. And I think, like, you know, one of the things I think about this is I do think it's scary the way that those people were you know, the internet was judge, jury, and executioner. A bunch of people that happen to be there. And that's really un-American, because even if the defendant did it, you know, she has rights and she deserves respect, right? That's our system is based on that. Yeah. You know, even if there's evidence that you committed a crime, that evidence might not reach the level of reasonable doubt and you're not convicted. Even if you are convicted of that crime, you deserve dignity and respect and a due process. And like, you know, Karen Reid deserved that, and so did those people that were kind of just thrown into the middle of this. They deserved that too, and they didn't get that. And that's what's scary about this. It's like a brave new world now. I know. Where are we going to just take people out there and try them on the internet and have no rules and no standards, and that to me is scary too.
Yeah, how'd you like to be the family of the victim watching this and watching the people who don't, that's what I don't understand it. People who are screaming at the cops and screaming at this idea of a conspiracy. They don't even know Karen Reid, but they're out there with signs every day.
That's right. And none of us know what happened, and that to me was scary about this thing. And the other thing I'll say, and I'm curious what you think about this, I thought the jury was very, you know, corrupted. How are you going to get a pure, clean jury in a situation like that on a second trial?
What the lawyers would tell you is you don't need a jury of people who don't know anything about the case. You simply need a jury of people who will decide the issue fairly. And that's still very difficult to do in this case. But I think, you know, back in my day when I worked for Lawyers Weekly, we polled jurors, and we were surprised at how serious they all took it, at least the ones that responded to our survey. You know, they recognize the gravity. So you hope that at least during the proceedings, they were paying attention to the evidence in the courtroom. Right. And I think they did. I hate to say it. I think they got it right in terms of the evidence.
I think I agree that most people would look at the evidence and would say, you know, there's too much doubt here. And I think that in a sense the system worked. That's how our system is designed. I said that already. Our system is designed to be this way. So it is what it is. And it takes a lot to convict someone, and that's a good thing. That's how we want it. That's American. Yep. And I think that our American system, it did work, even if maybe it didn't get a conviction. It did work given the quality of the evidence.
You want, the moment you're accused of something, believe me, you want it to be set up that way. You know
100%. That's as American as it gets, right? The right to make a defense and to have a trial by jury. That's what it's all about. Okay, let me give you one last one, because I know you're into music, and then that's it. One band to lighten the mood a little before we end.
Yep.
Oh, actually, we'll save this for next time. I got a better one. Boston Sports Minute.
Okay,
Dave,
Boston Sports Minute.
What do you got? What's going on? Boston sports, Red Sox,
yeah,
Patriots, something, save us.
We remain really optimistic about the Patriots. I can't wait. I can't wait for that. I'm going to be watching all those pathetic preseason games where like
100%.
those starters barely ever play, but I don't care. This is a big year. The Red Sox, I'm usually a cockeyed optimist when it comes to my Sox, and I'm starting to lose a little
Are
bit.
you a big Red Sox guy?
Yeah, I love them.
What's your
Sox
take
and
on the
Patriots.
Devers trade?
It made sense. As it happened, I was up in Maine at this retreat I go to once a year, and one of the participants was this dude I just met, and he works for the Cincinnati Reds. He's an advanced scout, and I asked him what he thought. He said, Red Sox got a fantastic deal.
Really?
And I said, why?
Really?
Those players we got back? He said, no. He said, getting that much money off the books provides incredible flexibility. So that's why they did it. The problem is, as fans, we're watching this product on the field, and they barely looked like they were like a 500 team with Devers, and without him, I got to admit. So I hope they do some maneuvering for the future and continue to build. There are some exciting young stars, but I'm sick of watching them lose 5-3 every night. That's what it feels like.
Exactly, and it's like they have an uncanny ability to lose close games.
Yeah.
And to leave runners in scoring position. I've never seen anything like. They
so
should be
frustrating.
better than they
Yes.
are statistically, but they just not. And it finally felt like they had built up some good vibes right into that Devers trade. They swept the Yankees.
Yep.
Looked like he had a big home run in that third game.
He did.
And then I'm at dinner that night, and I'm looking up the TV, and I'm like, wait, is this a joke? You just saved
did
your
seem
season,
like a
and then you
joke.
just traded Devers. It didn't make any sense. And so I don't know. I hate it. It's like, I get the whole salary thing, but I have zero confidence that they're going to spend that money, because they just seem like they really don't spend like they used to anymore.
It's true. I mean, I defend. I think it just doesn't. People say all they care about is their soccer team, and that it just doesn't make sense. It is this. I mean, Larry Lucchino passed away. God rest his soul. But the Henry group. A lot of those guys are still there. They've won 4 championships this century. It's more than any other team. How could they be so wrong-headed? And yet, the Betts leaving was a disaster, really.
Right. And that is the antecedent to all this, because if you just traded Devers, you might be able to tolerate it for the salary dump. But when you did this to Betts a few years ago, and you're doing the same thing now, it just gets tiresome as a fan.
They're going to trade the closer, Chapman, I think. That makes total sense. I mean, I would trade him as soon as you get you probably want to wait till the trade deadline, get the best offer. They'll get something good for him. He's throwing great, but he's not the future for us.
Yeah, how can they be so bad in one-run games and the closer has been so good?
Yeah,
do the math. Explain that to me.
I know. It's because no clutch hitting late.
None. They leave runners on base. It's like anyone I've ever seen. It's like banging your head against the wall. It's just infuriating. It should be better than they are.
Yeah.
All right, well, that's good. All right, well, listen, I want to thank everyone that listened to this episode of the Modern Medicine Podcast. Hey, thank you all. Have a great day. Write me with questions. I want your questions. Find me on Facebook. Find me on Instagram. Like us. Follow us. I'm trying to get to 1,000 followers. Dave, I've got about 200 and something now. So give me a like.
Yeah.
Give me a like. Give me a comment. Give me a share.
Like and a share.
Help us out. We're good in mission. We're good in purpose. Okay, thanks, everyone. Have a great day. Enjoy the summer. Be good. Happy 4th.